All right. Hello, everyone. Thank you for bearing with the technical sorting and everything right there. I am Susie Roy from SNOMED International and the host for the SNOMED CT research webinar series. Welcome everyone who is attending. As we're all getting used to, all of you attendees are currently muted and your video is disabled. But if you have any questions as we go along with today's presentation, go ahead and enter your questions into the Q&A box at the bottom of your Zoom screen, and we will get to your questions at the end. Just to let you know that this meeting is being recorded, and we will make these slides and the recording available later this week. This is the research webinar as mentioned, but we do also have other web series part of our SNOMED CT webinars. Both the clinical and implementation webinars are also just as exciting as this research webinar, so I hope you check those out. You can go to snomed.org/web-series to see all of those previous and all of the upcoming webinars in all three tracks of those web series. Just to give a little bit of a heads up for our March SNOMED CT research webinar, we will be featuring Dr. Fouad Rahman, who has presented in the past to our SNOMED CT community. He'll be presenting on Thursday, the 24th of March, computable healthcare data, challenges and opportunities of generating targeted insights and impacting real outcomes using machine learning and artificial intelligence. Should be a really exciting webinar, so I hope you all join us in March. And we just announced, so this is fresh off the, fresh news right here. Just the email went out maybe like 5 minutes ago. We have opened up our abstract submissions for the September SNOMED CT Expo 2022 will be held this year, September 29th through 30th. So just to cue people who are used to it being an October meeting, this one will be right at the end of September. So go ahead and submit your abstracts online starting now. Pretty exciting because this year, due to the popularity of the research and innovation engagement that has been going on in the SNOMED CT community, we now have a new stream called the Advances in Research and Innovation. This will be an in-person with some limited virtual sessions, so hope to see you all in Portugal. If you have any questions, go ahead and email me, sro@snomed.org, and I can point you in the right direction. So hope to see you all in Portugal. All right, and so just to get to our session today, I am so pleased to welcome Dr. Paulette Chandler to present today. So Dr. Chandler is a translational epidemiologist in the Division of Preventive Medicine at Brigham and Women's Hospital and assistant professor of medicine at Harvard Medical School. She aims to understand the association between biomarkers and risk of chronic diseases to develop innovative preventative lifestyle interventions. Today, Dr. Chandler will be presenting Hypertension Demonstration Project in the All of Us Research Workbench using SNOMED codes in the EHR. Really excited to have you, Dr. Chandler. And with that, I'll hand the screen over to you.
Great. It's great to be here, and I'm grateful that you all are using the EHR to transform how medicine is delivered and how care is delivered. So the All of Us Research Project, we did multiple demonstration projects on the Workbench with the alpha and the beta release just to see how well the data is worked, how well the data is accessed, and whether there are glitches in how the data has been loaded in. So I'm going to highlight how we did our hypertension research project, but then give you insight on what's available to you and anyone that wants to use this research workbench. The goal is to make data accessible to all communities. So the All of Us research program mission, it's to nurture relationships with over 1 million participant partners from all walks of life for decades. And we want to have a robust ecosystem between researchers, funders, as well as the participants. And our mission is to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all. And the goal is to deliver one of the richest biomedical depositories that's easy, safe, and accessible. So who is participating in all of us? People from across the US. Over 80% of all of us participants are underrepresented in biomedical research. And that's great because for this hypertension project, we included individuals from backgrounds that may not usually be engaged in research. And our age distribution is across the spectrum from ages 18 to 29, we even have some 80 to 89-year-olds. And you can see that we have a very diverse group. All of us New England, which is part of the system, which includes Boston Medical Center, as well as Mass General Brigham, the Harvard network, is aiming to enroll 90,000 participants. And our research project included the EHR data across the US. And it was nice to have our data, which had about over 17,000 individuals, so that we could see how our data looked compared to other groups. So what data are in all of us? Now we have over 400,000 participants, and we have electronic health record data, we have the participant surveys, and we have physical measurements. So that means that we have blood pressure measurements, weight, pulse, waist circumference, and then we have biosamples. We have DNA, as well as a host of, we're going to be getting metabolomics, all sorts of biosamples, urine and blood. And so there are many scientific opportunities available within the all of us data. You can develop quantitative estimates of risk for a range of diseases by integrating environmental exposures and genetic factors. We can also identify the causes of individual variation in response to commonly used therapeutics, which we call pharmacogenomics, because within the electronic health record, of course, we have detailed medication lists in there. And also in the surveys that we collect information on medications that are being used. And this data will allow us to develop solutions to health disparities. We also collect mobile health technologies such as Fitbit data and other mobile health technologies. Let's see here. Here we go. So how does All of Us Research Hub work? Well, participants share their data. This data is received and funneled through a curation pipeline within a secure repository. The researchers and participants visit the Research Hub, which is where the Workbench is where the Workbench hosts all this data. And then researchers can apply for data access and register for a Research Workbench account. Now, say you want to collaborate with researchers at the various universities that already have access to the data, you just reach out to a researcher at these various institutions and say, hey, I have a research idea. I would love to collaborate with you. The Workbench is also a great way to get preliminary data for projects that you may be thinking about. And one of our first ancillary studies using All of Us is our Nutrition for Precision Health. And we are recruiting participants that are already enrolled in All of Us. And then of course, we're encouraging others to join. And these individuals will be, they'll complete a baseline dietary survey, dietary exposure survey, and then they will be randomized to intervention diets and free living controlled feeding studies. And we'll examine the responses to 3 short-term intervention diets. And this study is already, in its works. So for this hypertension paper, or the Workbench project that we pursued, we wanted to see, could we replicate published data on the prevalence of hypertension? Could we use the electronic health record data to replicate published data from the bigger databases like the published data from NHANES, which is a CDC-based cohort? And within the Workbench, we identified 103,490 participants that had electronic health record data with diagnostic codes for hypertension and antihypertensive medication use. And this was based on the hypertension algorithm from eMERGE, which is an electronic medical record project where they have developed algorithms to identify different diseases: hypertension, colorectal cancer, depression. Those are some of the diseases that they've worked on. And so our hypertension definition was defined as a SNOMED code for essential hypertension on at least 2 distinct dates, and they had to have at least one medication from common hypertension classes, such as, beta blockers, calcium channel blockers, the medications that we usually use to treat hypertension. And what we found is that we could replicate the prevalence of hypertension in these 100,000 individuals compared to NHANES, which has about 6,000 individuals. And the distribution of hypertension by age was similar, and by gender was similar in terms of when you look at it in comparison to NHANES that we had for individuals 18 and over. There was a prevalence about 26% compared to about 28% in all of us, in NHANES. And then for males, the prevalence of hypertension overall was about, in individuals over 60, it was over 50%. And similarly for males in NHANES, it was over 50%. So we see that there's a heavy burden of hypertension, and it increases as people age from 18 and over. That's the overall. But when you look at subgroups, 18 to 39, which is in orange, you see that the 18 to 39 age group has a lower prevalence of hypertension than the over 60 age group. And that's what we see clinically. So this was congruent with the findings of NHANES as well as what we've seen clinically. So we were also able to look at hypertension by ethnicity and race. And Blacks, unfortunately, have the highest prevalence of hypertension, with over 36% of Blacks in this cohort that had hypertension. 36% of these individuals were Black versus 25% white, and Asian 20%, and those that classified themselves as Hispanic about 20%. And then we were also able to look at it by census division, because we have the information on where these individuals live within the workbench. So we could see that the Southeast Central had the highest prevalence of hypertension. Over 45% or 43% of individuals in this cohort of 103,000 people were from the Southeast. And if you know, the Southeast is often called the stroke belt. North Carolina, South Carolina, Mississippi, Alabama, Tennessee, those areas, they have a very high prevalence of stroke, and that parallels the high stroke, the high hypertension prevalence that that region has. And the mountain region, which would be like Colorado and other areas in the mountain region, they had the lowest prevalence of stroke. And the Pacific Northwest, which would be Oregon, Washington State, had a low prevalence also. So when we think about these, this distribution of hypertension, you might say, well, what can we do? How can this data be helpful in transforming care and also delivering personalized care? Well, one way you could think, hospitals or healthcare networks could use this hypertension algorithm. Now that we've validated it in all of us, the eMERGE data set was used to develop this algorithm. And now we've validated this eMERGE algorithm using SNOMED codes and medications to say, look, we can identify individuals that have hypertension. And if we can identify them, can we develop personalized recommendations? Could we send text messages? Could we have clinicians say, okay, this is my panel of patients with hypertension. What targeted efforts can I develop to improve their blood pressure control, whether it be lifestyle, encouraging them to exercise, looking at the environment, food deserts can help healthy food in these areas? Can we, there are the host of things. One of the things we think about though is food. And we know that there are many studies that show the impact of food on blood pressure. We have the dietary approaches to stopping hypertension study, which showed that individuals that consume a diet rich in fruits and vegetables, low in sodium, no more than 1,500 milligrams of sodium, they can experience about a 10-point drop in blood pressure. And so I'll dive in a little bit in terms of what the hub has, and then I'll just open it for questions. So the research hub or the Workbench has a data browser, data snapshots, a survey explorer, and it's very, it's a graphic user interface. So it's very intuitive to use. And there's a data dictionary with a concept set selector. This says coming soon, but actually this is available now. This is an old slide. And it became available in 2020, the Cohort Builder Network. And it's registered. You might think, well, how is privacy preserved? There are lots of different algorithms that are running in the background to preserve privacy in terms of, ages are switched, and a lot of different algorithms are running in the background to ensure privacy. And then anyone that accesses the Workbench has to go through ethics training. They have to test, they, sign an agreement that they will use the data appropriately. And so how do you access this? You sign up. You can sign up as an All of Us researcher. And if you don't have the, the data access privileges, you can collaborate with investigators that already have that access. And then you can create a project and you build cohort sets. So I'll just show you just, All of Us has lots of different support platforms, and they, will allow you to understand how to explore the concepts and the concept relationships within the framework of the Observational Medical Outcomes Partnership. And it shows you how the concepts are developed and the concept ID. There's a dictionary that will give you the concept ID. If you're looking at hypertension, they use the hypertension concept ID. And then you can identify, whether for depression, the concept IDs are very, very familiar to you in the SNOMED community. And so I'm going to skip out of that. And then there's also the concept set selector, which allows you to build your cohort based on your concept set selector tool.
We can't see anything for the
set
selector.
I'm sorry.
I think it might be on the other screen.
Okay. Could you see the other one?
We just see your slide right now.
Okay. So I'll pause here to answer questions, and then I can share my screen to show those other pieces. But in general, the data is organized in All of Us based on the Observational Medical Outcomes Partnership Common Data Model. And that's how the concepts are organized within there. And you can visit the All of Us Research Hub. You can visit the All of Us Research Hub. You'll just have a very superficial view of the layout, and then you can sign up to have access. And then of course, when you really want to do the data analyses, then there's a more formal process to access the data. So I'll stop sharing my screen and see if there are any questions.
That was really cool. Thank you for that introduction and description of some of your current work. And I mean, it is so incredibly important because right now, while we are gathering more and more data from clinical records and everything, but now being able to actually disambiguate those data based on gender, based on different races, that's really going to begin to allow us to not only analyze those data, but also go that next step in being able to, as you said, customize actual treatments and interventions and being able to really help the patient. So seeing this is really, really exciting, Dr. Chandler.
Right. And I forgot to mention even gender orientation. We have, we have data across all the spectrums of demographics, which will allow.
Yeah. So with regards to, because of course here with the SNOMED CT community, we are, while we love big data and big data analyses, we are all the way down at the standards level, with SNOMED CT being the terminology that these data can be encoded and then, as you have demonstrated, extracted from. What can we do to help you in your data analyses and later on? What kind of suggestions do you have for us from the SNOMED CT community that could help you?
We're always looking for algorithms for diseases. So if people have algorithms that they've developed for different disease endpoints based on SNOMED CT, then and you have an idea for a research project related to that algorithm, reach out to us, because we're always looking for additional algorithms. eMERGE3 has developed a number of algorithms. The other project that's developing a lot of algorithms is eMERGE4, which is a continuation of eMERGE3. But investigators always want different ways of more rigorously capturing the cohorts that they need to capture.
Great. So a couple of questions have come in. Looks like we have a two-parter from Dr. Charles Gutteridge. First, can you tell us more about the curation process? What is the ETL and how is it governed? And then he also followed up with, is the All of Us open on a global basis?
The All of Us, so in terms of the curation process, the institutions that agree to share their data, of course, subjects have to grant permission for their data to be shared. But if they agree to share their electronic health record data, then that data is flowed into Vanderbilt, which is our main data processing site. They curate it based on SNOMED codes. They have algorithms that curate the data, and there's a 6-month lag time. So for example, for us, we were doing an obesity analysis, and we were surprised that we had only a certain number of participants from New England, and we knew what our recruitment numbers were, but we were like, okay, well, why are so many missing? And it turns out, there's that 6-month lag time, and that will vary, at least for New England, that's the lag time, but that will vary from institution to institution. And one of the purposes of doing the Workbench project was to determine how well is this data being curated? Are we finding gaps? And for example, for the BMI data, we looked at the measurements, the physical measurements that were captured when participants came in and measured, and we correlated that with what was recorded in the electronic health record. And we correlated that with whether they, had a diagnosis of obesity on their medical record. And it's amazing, the physical measurements that were collected at the time of the participant's visit to a site correlated. I mean, it was like 99% correlated with the with the electronic health record recorded measurements. And similarly with blood pressure, we saw a nice correlation between what was measured at the physical visit versus what was in the EHR.
Wow, that's really cool.
And then in terms of whether it's accessible around the world, it is. Yes, you just have to go through the agreement process. And ideally, it's easier if you collaborate with someone an institution that's already a part of the All of Us network, because that makes it a lot easier. And we at Harvard, we're always welcome to collaborate with individuals around the world, and other institutions too are very open to collaborating. And you can see what projects are currently ongoing at the All of Us Workbench. That's publicly available information.
I was going to say, I do recall seeing a list of various institutions that have either had research programs like early on in the All of Us program or are current somewhere on the web page. And so I think if people go there, they can also see who potentially would be open for collaborating on there as well.
Right.
John Schneider entered something, but it says question has already been answered, so that's great. Did you use expression constraint queries to define the phenotype of hypertension?
We did. I mean, in terms of meaning the definition was systolic blood pressure less than 140, or systolic blood pressure greater than 140, greater than or equal to 140. Systolic is the top number, greater than or equal to 140, and diastolic blood pressure greater than or equal to 90. That was our constraint for defining an individual with blood pressure. But are you referring to constraints on the SNOMED CT listing, or which constraints are you referring to?
Dr. Gutteridge, do you mind if I just unmute you? I don't know if you have your headset on. That might just be easier. Let me see if I can find you.
Thanks, Dr. Chandler. Yes, I was wondering, whether you just selected some relevant codes from by using the browser, or whether you wrote a query using ECL to define all codes that might relate to hypertension, so that you pick up rarer forms of hypertension.
Yes, we did. We used the eMERGE-3 algorithm, which brings in a lot of different codes, but then it drills down to essential hypertension, because there's pregnancy-induced hypertension related to pregnancy. So we had to screen out women that had blood pressure measurements that were pregnant, and we also screened out individuals that were in the emergency room that had blood pressure measurements. So we did a lot of screening, but we pulled in the eMERGE-3 algorithm, which is at that eMERGE site. You'll be able to link to that when you get the slide deck. You'll see how that algorithm works, and it pulls in a variety of SNOMED codes for elevated blood pressure, hypertension, and the various ones that can be associated with an elevated blood pressure.
Thank you very much. Thank you.
Thank you, Charles. I do know that Dr. Chandler needs to.
Yes, unfortunately, I have an emergency
so.
meeting today. I apologize for a short session, but it was a pleasure.
Thank you so much. No, thank you for presenting to us, and it would be absolutely great to have you and or any of your colleagues who have some follow-up research, to this, or additional research coming in the future to expand on this, because I know that the SNOMED community would be really interested in hearing, the next steps.
Yeah, we have 3 other projects, and the eMERGE-4 project, it uses SNOMED codes too, and that's an amazing. We have all sorts of projects going on within eMERGE-4.
That would be, we would love to hear, as the results come from those in the future. So please keep us in mind, and we will definitely be watching your work going forward. And if anyone on today's webinar has any additional questions, follow-up questions, please go ahead and email me, sro@snomed.org, and I can channel your questions over to Dr. Chandler. Other than that, thank you again, Dr. Chandler. It was so much. Great to meet you.
Great. And I saw the question about the UK Biobank. Yes, we do have a lot of researchers that are using the UK Biobank also. All righty. Take care.
All right. Thank you.
Bye-bye.
And thank you, everyone. And I'll see you next month. Bye-bye.